My name is Jane McNaughton and I'm one of the specialist optometrists at the Leicester Royal Infirmary.
More recently, we have a slight shift change. We use person-first language in disability. We talk about, rather than a visually impaired person, it's a person with a vision impairment.
I was talking about low vision services and how they've changed since I entered the profession almost 30 years ago now. So what has evolved, what hasn't evolved? Well, it certainly was quite different to what it is now. I think we were very focused as optometrists within the hospital service on prescribing devices, but now it's a more holistic approach. We talk about aspects of services, the impact of sight loss, the functional impact of sight loss, and what we can do to sort of try and assist. And as a result of that, we're now working more alongside other healthcare practitioners, in particular the vision rehabilitation sector, which has been really important, particularly where I work in Leicestershire and Rutland. We work directly with our vision rehabilitation specialists, and that has been a huge improvement in the overall service that we provide.
I remember us debating the name. We came up with iClinic Link Liaison Officer, and it didn't really roll off the tongue, so we dropped the link and kept it as an ECLO.
The ECLO role was initially created by the RNIB, and this was in response to patients saying, we don't get enough information at the point of certification. And at the end of the 1990s, the RNIB approached City University to create a new accredited course for this new potential role that they wanted to run. And that got off the ground at the beginning of the 2000s, and that was the ECLO role, the iClinic Liaison Officer.
The idea was it was for patients and or service users, as they're now come to be called when we're working in that sector, for any patients with any level of degree of loss and any need for support, regardless of certification and registration, and at any point in time on their sight loss journey.
Well, certainly where we are, we're quite a large department in Leicester. We have 3 ECLOs, of which we would not be without. They take over the burden of doing all the certification, the registration process. They sort of have access to all our patient records, so while somebody is waiting to maybe speak to the consultant, they will take somebody in and have a discussion about them or any particular functional needs, any difficulties they've got, or any even emotional impact that they have with their sight loss, and be able to put them in touch with our local charity Vista, who provides the vision rehabilitation services. So it's a link between the hospital and health and social care in the community.
What are they? Who are they? Well, they were previously known as rehabilitation workers, I mentioned Richard Cox, rehabilitation officers, ROs, or rehabilitation officers of visual impairment, ROVIs, and you'll still find these acronyms being used across the country anyway. But vision rehabilitation specialist is a term that we now use that has actually just come in the last few months.
Well, the role of the Vision Rehabilitation Officer has been around for a long time. It's just different names, but that is their now recognised name, and they're part of a professional register, which is great for recognition. When we refer somebody to a Vision Rehabilitation Specialist, they will contact the patient and organise to do a home visit and do an assessment within the home, again looking at functional needs with the focus on independence and safety. And they may then go on to organise provision of additional lighting or additional training, for example, mobility training, cane techniques, other techniques of mobility, assist with form filling, organising, helping with benefits, for example. So it's a very extensive range of services they do provide, but it starts within the home after the home visit.
But what is vision rehabilitation? I remember sitting next to somebody at a meeting who really didn't know and said, vision rehabilitation specialists, they just give out these liquid level indicators. Right, anything else? That's about it, isn't it? Right, no, is the answer to that. And the great advantage of our low vision service in Leicestershire and Rutland is that when I run the low vision clinic, when myself and my colleagues are doing a low vision clinic on the day, I have a vision rehabilitation specialist there. They work with us all the time. I have access to their records through their database. I know what they have done. So if I have a patient in my room whose visual acuity is significantly changed, or they've recently become widowed, or they have moved house. That's a really good opportunity for me to say, right, I've sorted out your magnifier, I've increased it, and blah, blah, blah. Have a chat here to Vicky, and she will now go through what else she can do for you and maybe arrange to have an appointment. How lucky are we to be able to working right alongside our vision rehabilitation team?
I think be aware of local services, know who your vision rehabilitation specialists are, and they can find out by joining the Rehabilitation Workers Professional Network, and you can find out who your vision rehab people are locally, but also to get to know your local ECLO. Some may not be called ECLOs, they might be called patient support services, but either way, there will be hopefully somebody within your local department, and that's your link in and understanding how services may be provided.
So, hospital low vision clinics in 30 years from now, well, I'm going to be back playing golf, but despite improved detection and treatment, sight loss is here to stay. Despite our diagnostic techniques, our numbers of patients are increasing, and I think that was a major takeaway today, nothing surprising. Whilst we have huge varieties of roles within our NHS, and they are only going to continue to grow with fantastic reasons and good reasons, as we heard with our initial discussions this morning, we still need to review our core services, and low vision is one of them. And 10, 15, 20 years from now, it's going to be mayhem in our low vision clinics. We need to expand our services.